Hi, everyone, and welcome. My name is Jeremy, and I am a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located across the nation in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at www.ehncanada.com. Just in terms of housekeeping, everyone is on mute for today's webinar and cameras are off, but please feel free to use the Q&A box at the bottom of your screen to submit any questions for our speaker. We will try to get to as many questions as we can at the end of today's session. Today's webinar is being recorded, and we will be sending out a follow-up email next week that will include the link to the video, today's slides, any useful resources, as well as your CEU certificate. I'll remind several times throughout the presentation that it is being recorded and will be shared with all of you, but just want to reiterate that the CEU certificate will be included in next week's follow-up email. I am located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence today in Halifax. Halifax is located on the ancestral and unceded territory of Mi'kmaq people. If you're new to this work and want to find out whose land you are on or grew up on, check out www.native-land.ca. Many more of you may be physically present elsewhere. I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now to get to today's session, RTMS and ketamine, treatment-resistant depression. We have the pleasure of welcoming Dr. Ahmed Saleh. Dr. Saleh is a psychiatrist licensed by the College of Physicians and Surgeons of Nova Scotia. He completed his psychiatric training through Dalhousie University in 2017. Dr. Saleh has experience in general adult inpatient psychiatry, including diagnosis and treatment of mood disorders, psychotic disorders, anxiety disorders, substance use disorders, and trauma and stressor-related disorders, among others. He is an assistant professor at Dalhousie University and is involved in teaching and training medical students and psychiatry residents. He works as a staff psychiatrist at the Valley Regional Hospital and maintains a small practice providing psychiatric care to CAF members, veterans, RCMP, and other first responders. Dr. Saleh helped co-found and is acting as the medical director of the ANSR Clinic. ANSR Clinic is the first clinic in Atlantic Canada to offer RTMS in the treatment of psychiatric illness. Please help me welcome Dr. Ahmed Saleh.
Thank you, Jeremy, and thank you for having me today. So I was hoping to discuss briefly RTMS and ketamine, and these two treatments are quite exciting, and they offer a wide range of treatment options for psychiatric disorders. But in the interest of being more focused, I chose to talk about treatment-resistant depression. Because RTMS and ketamine have the most evidence in the treatment of depression. So I'm gonna break down my slides today into going briefly over ketamine initially, then discussing TMS. I anticipate that my talk will be about 30 minutes long. This would give us the opportunity to have the question and answer session towards the end. So, sorry, I'm just. So to start, I just want to open up with a conflict of interest statement. So as Jeremy indicated, I am an assistant professor at Dalhousie University. I'm also an inpatient psychiatrist at the Valley Regional Hospital. That's part of the Nova Scotia Health Authority. I also take on the role of a medical director of the ANSR Clinic, and we have been operating for the last 5 years, offering RTMS treatments, and over the last 2 years offering ketamine treatments in the treatment management of psychiatric disorders. I'm also the director of the neuromodulation clinic at the Valley Regional Hospital, which offers RTMS through the public system. I have no major conflict of interest relating to this talk. outside of receiving occasional honoraria for academic talks. So to start, I would like to just briefly go over depression. Depression as a psychiatric illness, it's when a person experiences long-term low mood, inability to enjoy life, lack of motivation, poor concentration, poor energy with increasing suicidal ideation. According to the DSM-5, one needs to meet 5 out of 9 symptoms to be diagnosed with depression. But in looking at depression, not all depressions are the same. So depression is a heterogeneous group of disorders that involve multiple neurotransmitter systems. More specifically, the way we've been treating depression has been focusing on the treatment, modulating or adjusting the monoaminergic neurotransmitters. That's serotonin, dopamine, norepinephrine. But the antidepressants that we've been using for the last 50 to 60 years could only take you so far. And when I prescribe an antidepressant to a patient, it's usually, I expect that 1 in 2 patients are going to show some sort of response. Well, actual real life treatment of depression is the response rate is even lower. So antidepressants really have a marginal benefit, 10 to 20% over placebo, which is not that great in the treatment of depression. 30 to 40% of the depressed patients do not respond to conventional antidepressants and end up having to be switched to another medication from a different class, or even considering augmentation strategies with other medications, which also have a lot of risks. And that's a lot of time a person remains depressed while attempts are made to find the right treatment option. Unfortunately, a third of the patients with depression end up with a treatment refractory course. And that's what I would refer to as treatment-resistant depression. There's many definitions in the literature of what treatment-resistant depression, how treatment-resistant depression is defined. But the most common one is an inadequate response to at least 2 trials of antidepressants. Conventional medications have been focused on the monoaminergic neurotransmitters, as I said, with limited benefits. So it is quite exciting to see that there are new emerging treatments right now for the treatment of depression. So, and those treatments include ketamine in all the forms of its delivery, IM, intranasal, or IV, and RTMS. So I'm going to start by giving a brief overview into ketamine. So ketamine is an anesthetic. It's been widely used as an anesthetic. It's got many receptor properties. It also could be used in the management of pain. It was the first derived from phencyclidine, PCP, which is no longer used in medicine for human purposes. It still has some use in veterinary medicine. It's a substance of abuse, also known as angel dust. So when it was first derived ketamine was derived from it. So PCP is a controlled substance, Schedule 1 under the Controlled Drug and Substance Act. So its activities that include sale, possession, production is illegal in Canada, unless it's for authorized medicinal, scientific, and industrial purposes. And with the use of PCP, this substance, when abused, induces a trance-like state, out-of-body experiences, causes a lot of pain relief, sedation, severe behavioral disturbance, and memory loss. So, as I said, there's no human medicinal purposes for PCP at this point. However, ketamine was first synthesized in 1962 by an American scientist, Calvin Stevens, and it was found to be a very useful substance, drug for the anesthesia purposes. It produced less side effects compared to PCP. However, at higher doses, it still had some emergence reactions with patients emerging in a dissociative state after being exposed to the drugs. So in 1963, it was used as a veterinary anesthetic. First human testing for ketamine was in 1964, which was found to have a shorter duration of action and duration of action. So it could be used better for the induction of anesthesia or for minor procedures. It's still commonly used in pediatric anesthetic anesthesia and procedure sedation in the ER at this point. It causes less hallucination and way less side effects compared to PCP. And it was dubbed as a dissociative anesthetic because of the dissociative effects. So we continue to use it as an anesthetic up until the early 90s, where a group of scientists from Yale have noticed that low dose of ketamine could mimic some acute psychotropic effects. And they found that there's mood benefits in patients who are emerging from procedural sedation with ketamine, even after a single dose. And there's also other evidence. There's a 2008 analysis, systematic analysis, that found that burn victims who were given ketamine were less likely to develop PTSD following that. And there was also another clinical trial in 2014 that saw 41 patients with their PTSD symptoms diminishing within 24 hours. And this lasted for up to 2 weeks. So in addition to minimizing the distress, there is also observation that the effects are maintained at least for a few weeks to a couple of months from its administration. So ketamine is quite promising in the for treatment-resistant depression, and in the next couple of slides, I'm going to focus on that. It also has some indications, and there's evidence and its benefit in the use and the treatment for bipolar depression, PTSD, and to a lesser extent OCD. In the short term, it's relatively safe. However, long-term studies need further investigations. There have been ketamine clinics operating in the U.S. For over 5 years, and the safety parameters are still promising. There are no significant long-term consequence, although we don't have the 10-year data points to suggest that. And I think it's also a promising option because for our patients who have failed 3 or 4 antidepressants, multiple augmentations with different strategies, the typical option would have been to go straight to ECT, electric shock therapy. And for patients who actually fail ECT, there's little guidance. We can't really direct on what the person should do after they failed ECT. So having this in our armamentarium is quite useful. I just wanted to put this slide in to highlight a couple of things. So I've talked about the monoaminergic, the monoamines, and how our antidepressants have been focused on managing them, treating them, boosting them for the treatment of depression. This little guy here, glutamate, is the most abundant neurotransmitter in the brain, and it's an excitatory neurotransmitter. Ketamine, through this cascade of events, end up stimulating the NMDA receptors and the AMPA receptors as its main endpoints. So in boosting glutamate, this is where the antidepressant effect comes from. AMPA receptors are implicated in long-term plasticity, or the brain's ability to modify and repair itself over time. NMDA receptors have been implicated and have a lot of functional use in memory and spatial awareness. So with this little cascade of events, this is how ketamine would end up using. Ultimately, promoting this little guy here, the BDNF, the brain-derived neuropathic factor, which also promotes long-term neuroplasticity. So Ketamine works on the postsynaptic NMDA receptor antagonism, so it blocks NMDA receptors here, increasing the presynaptic glutamate, increasing glutamate within the synaptic cleft, so boosting its presence in that area. And this is hypothesized to increase the AMPA and NMDA receptor flux. So NMDA receptors play an important role in learning, memory, and spatial memory, while AMPA receptors are more implicated in long-term neuroplasticity. And a lot of studies have demonstrated that with the use of ketamine, and mostly the studies put out by Janssen for esketamine, is that the high-density NMDA receptors in the prefrontal cortex, the part of the brain that is presumed to be most affected in depression, the pyramidal cells in the hippocampus have shown that they increase in size and proliferate more. There's a demonstration of efficacy of ketamine. So multiple small studies have shown immediate and profound alleviation of depressive symptoms in up to 75% of the patients who have been treatment refractory up to this point. This is quite promising because, as I was saying, the conventional method would be to try someone on an antidepressant, wait 6 to 8 weeks until you reach an antidepressant dose, and if it doesn't respond, you switch to another one, wait a few more weeks, maybe an augmentation here and there. These are weeks where a patient remains depressed. With ketamine, the effect or no effect is measured shortly. I'll talk about a single dose or maybe 2 or 3 more doses. The acute courses are 4 weeks at the most, so patients would know within a month if this is a treatment that's going to cause them to benefit or not. And a lot of them have a profound response from the get-go. And the length of the antidepressant effects, of course, varies from person to person, but may as well be sustained for 2 months or more before someone needs another booster session or follow-up for ketamine. So ketamine is a prototypical drug, so it's a drug of its own. It's in its own category, and it's considered a rapid-acting antidepressant. The initial studies have shown that the effect size have been 64 to 71% from a single dose of ketamine. So that is quite pronounced. When my expectation from someone with major depression getting an antidepressant is about 30%, and less so for someone with a treatment-resistant depression. However, in real-world studies, and that's mostly related to esketamine, the intranasal ketamine, the clinical samples could be around 50%, which is still much better than your conventional antidepressants. So with everything, as with everything in medicine, ketamine has its adverse side effects. Most of the adverse side effects reported with ketamine are, and especially the long-term ones, are brought from the recreational substance use. We don't have any clear long-term data on ketamine and its use because it's been used in anesthetics, so these are usually single procedures. However, the short-term, the 1-year studies of efficacy of safety have been quite promising. 5-year studies are also quite promising. Beyond that, there's more evidence that's needed. A lot of the concerns with the long-term ketamine use is the possibility of cognitive side effects, memory impairment issues, addiction issues. Is there going to be any dependence that could be caused by long-term ketamine use? So far, it doesn't look like it, but more long-term evidence and studies are needed. Also related to ketamine bladders, hemorrhagic cystitis that could occur with the long-term ketamine use. These are, myself or any of the colleagues I've worked with have rarely seen that, especially in the low subanesthetic doses we use for ketamine. So the antidepressant effect that ketamine induces occurs at very small doses. Higher doses are more sedating, so the antidepressant effect is usually lost there. So that's my initial talk on ketamine, I'm going to shift gears and talk about RTMS, which stands for Repetitive Transcranial Magnetic Stimulation. So RTMS is it's a mode of stimulating the brain, a neuromodulation technique affecting the brain cells. So the brain cells, the cortical cells communicate with the neurotransmitters. This the monoamines that we've discussed and glutamate there. And they also have a basal electrical tone. So the brain as an organ is an electrochemical organ, just like the heart, for instance. And when people are depressed, we could, and they're kind of frozen in that. ECT kind of helps reset the brain by resetting that basal tone. We don't have a way of measuring it. We don't know what it should look like, but we know that affecting it with TMS, with ECT, shows profound responses when it comes to depression. Just like the heart, when someone's heart stops and they use electrical paddles to defibrillate and get it going again. So by running an electrical impulse in a coil, we're using Faraday's law. They create an electromagnetic pulse placed over the scalp. It could help either inhibit or excite neuronal activity, and in this manner help treat depressive disorders. So RTMS uses electromagnetic fields to stimulate areas of the brain that is either underactive or overactive, hopefully returning it to a healthy pattern of activity. The use of electromagnetic fields to non-invasively stimulate the cortical neurons. Unlike ketamine, when someone gets a dose of ketamine or gets a session of ketamine, we advise that they get brought to the session by someone and driven back. Where TMS, they can drive to the procedure, drive back from the procedure. It does not affect a person's overall function for the day. RTMS is quite safe and has way less side effects compared to other procedures. So RTMS uses powerful focused magnetic field impulses against when it's placed against the scalp to target specific brain lesions. And this is the only treatment in psychiatry that could focus on parts of the brain. With the medications, you affect the whole brain positively or negatively because of the side. So does ketamine. But with TMS, you can focus the stimulus on specific parts of the brain, and from there at the effects, minimizing the level of side effects. So TMS encompasses a wide spectrum of treatments because with TMS, there's the treatment stimulation could be decided by the type of coil used, the area of the brain stimulated, the dose of the stimulation, the pulse width, how long you stimulate, how long you rest. So there are different parameters and different protocols and different parts of the brain to stimulate. So for depression, you could stimulate the left pole with a low frequency, the right with low frequency, the left with high frequency. For OCD, there are orbitomedial, dorsal stimulations. So it's where you place the coil, given the treatment parameters, you could decide to treat specific psychiatric disorders. This treatment is usually given daily, for 30 up to 30 treatments. So it's a big time commitment. Patients have to drive in, get the treatment once a day, 5 days a week, 30 treatments. They know if they're going to respond around 20 treatments. There are accelerated protocols that are coming up, but the general protocol is that they get a daily treatment. It's actually a miracle that we have TMS. We've been, in medicine, people have been experimenting. Scientists have been experimenting with ways to stimulate the brain and stimulate body parts using electrical fields for ages. So since the 1830s, I referenced Michael Faraday, where we discovered that changing magnetic fields can generate an electrical current. And from 1830s onwards to the early 1900s, there have been a lot of experimentations. One of them is called diathermy, which the early ages of psychiatry used electrical fields to try and create changes in the patients with psychosis, the brain activities, then more of a rudimentary ECT machine. However, in 1985, when Anthony Baker and his group found that stimulating a patient, and I think they used 5 stimulus. Right now, we know that more than using the efficacy of a treatment correlates with how long and the number of stimulus administered. But this person seemed to have responded quite nicely with 5 treatments. And at that point, it wasn't quite sure. People weren't quite sure where to stimulate the brain. So with little treatments on a part of the brain that they stimulate, they saw that this person that had an antidepressant effect. I just imagine if they didn't get the response, if they would have pursued their research. However, that's when the first TMS machine was devised, specifically in the treatment of depression. And since then, it has taken a life of its own. So right now, according to the Canadian Mood and Anxiety Guidelines, RTMS has level 1 evidence in the treatment of depression. So its efficacy is equivalent to any other antidepressant. So TMS was first approved in Canada for treatment of depression in 2003. And this talk is in 2022, and you can see it's still not widely used, but as a treatment, it is quite effective and quite safe. And there are specific treatment protocols for PTSD, OCD. It also has other uses in the management of tinnitus, in the treatment of smoking cessation, substance abuse, some neurological disorders like Parkinson's. So there's a wide variety of use for RTMS. So this happy guy here is Anthony Baker and his group, and that's the first TMS machine. And these are 3 examples of RTMS machines available. This is the MaxStim device. This is the BrainsWay device, and you can see it's this is a form of deep TMS. And with these specific coils, they have coils designed for the treatment of PTSD coils, OCD coils, depression coils. And this is a MagVenture device, which is widely used in Canada, and the one we use in our clinic. And another, that's all the device we use in Nova Scotia, essentially. So with the application of this probe, there's a high voltage that's run through a capacitor, about 3,000 volts. And the capacitor discharges the current at up to 8,000 amps. And this produces a powerful magnetic field up to 2.5 thetas. And then this is converted into either inhibition or stimulation of brain networks. I just wanted to add a couple of studies here for reference. So this is from the Journal of Clinical Psychiatry in 2018, where high frequency TMS was after doing the 1,300 patients, compared the chances of response in the treatment of depression. The odds ratio was 3.3. So a person getting TMS was 3 times more likely to have a response in compared to just an antidepressant. And remission, it's where the full resolution of symptoms. They're also 3 times more likely to have full resolution of symptoms compared to antidepressants alone, which is quite a response. And comparing RTMS to sham, you can see that the 38% who received RTMS responded versus 15%, which is attributed likely to placebo, with the odds ratio of 3 times more likely to respond. And as I was indicating here, that according to the Canadian Network for Mood and Anxiety Treatment, Ketamine guidelines, which is the major guidelines that psychiatrists use in the treatment of mood disorders like bipolar and depression, TMS has level 1 evidence. So it's a first-line treatment for depression. That, despite the fact that shows that there's an abundance of evidence when it comes to RTMS and in the treatment of depression. There are other ways, other modes, neuromodulation modes in the treatment of depression, like TDCS, transcranial direct current stimulation, or vagal nerve stimulation. They do have evidence, but I would say that TMS would be still has comes superior in comparison to them. So that's where I'll end my talk, and I am happy to receive any questions. Thank you.
Perfect. Yeah, thank you so much. Lots of questions, which is good. Like I said, we have a very engaged audience, so we can get into the questions. So if you could just kind of highlight what is refractory depression? Refractory depression.
So refractory depression is treatment-resistant depression. That's when a patient fails to respond to at least 2 trials of antidepressants. The definition is this is the most widely used definition, but there are others that would define it as failure of 3 antidepressant trials, different classes of medications. But for the purposes of a stock, I would define it as the failure of 2 antidepressants.
Perfect. Thank you so much. I will remind everyone just to please use the Q&A box located at the bottom of the screen next to the chat function. Unfortunately, the chat function, it will get lost in the shuffle of everybody else communicating. Have they thought about using ketamine and RTMS on treating personality disorders, in particular borderline personality disorder? I know you kind of alluded to that at the beginning, that you're focusing on treatment-resistant depression, but if you could kind of just speak to personality disorders as well, please.
There's no high-level evidence when it comes to the treatment of personality disorders. In our clinic, though, I have found that RTMS has had, especially with the low-frequency right stimulation, it exerts a mellowing effect, and I did see some benefit in borderline personality disorders, especially the ones with disordered eating, so also anorexia. And ketamine less so. I find that ketamine is helps more with the depressed type, but I think TMS would I would certainly suggest it for in the treatment of BPD. Of course, after in addition to the dialectical behavioral therapy, which remains the first line treatment.
Perfect. Thank you so much. I know you spoke to the efficacy as well, but can you speak to the efficacy using ketamine to treat persistent depression resulting from clients also dealing with chronic illness and pain?
Yeah, I can't give you a specific number, but I would say that for the major depressive disorder, I would say that the response rate is around 60%. For dysthymia, persistent depression, that is much lower. I have found that patients who have double depressions, so dysthymia and a bit of depression, that it picks up their dysthymic baseline a bit, but I cannot give a clear number on the treatment of dysthymia itself. However, if there's a pain syndrome associated with the depression, or at least feeding into the depression, I think ketamine is a very has a high utility, and it should be explored at that point.
Perfect. Thank you. So what is the recommended duration of treatment for ketamine, at what point should it be discontinued?
So the way we have our protocol set is that we follow our patient. The acute course, it varies on the mode of delivery. So for intranasal, it's about 4 to 6 weeks. For IV ketamine, it's about 6 sessions, so twice 2 to 3 treatments a week for 3 weeks, followed by 1 treatment for 2 weeks, to taper them off. I would treat the patients and follow their MADRS scores, the Montgomery-Åsberg Depression Rating Scale. Once it dips under 12, that's when I start to stop. That's when we stop the treatment and monitor the patient, see how they're doing. Some may not require any further treatments. Some may need a booster session. However, for us to offer ketamine for any person, the person needs to be on an antidepressant. So a person needs that as a foundation for their wellness. So to see if the antidepressant will be sufficient in maintaining the remission of their symptoms.
Perfect, thank you. So there are a couple questions surrounding the addictiveness of ketamine. So they say, forgive my ignorance, but would a patient have to continue increasing their dosage as time went on? My understanding is that ketamine is quite addictive.
Yeah, so at the low doses that we use, the addictions there has been no report of iatrogenic addictions when it comes to ketamine, and certainly at the spacing of the dosage that we offer. And another, I didn't go into the exclusion and inclusion criteria of ketamine because there are medical exclusions and there are psychiatric exclusions. So for the psychiatric part, we do not include people who have an active substance use disorder when it comes to specifically when it comes to the use of ketamine. So just specifically for this, or an active psychotic disorder or a psychotic depression. But at this low dose, the chances of it becoming an addiction is still low.
Perfect, thank you. So lots of questions about RTMS and comparing it to ECT therapy. So how does RTMS compare to ECT therapy, and what is the holdup in this being widely used?
Oh, that's a great question. So for myself, when I'm introducing a treatment algorithm to a patient, I adopt a stepwise algorithm. So the stepwise, let's try an antidepressant, first line antidepressant. Then I'd go into a second line, then an augmentation. If someone has intolerance or failed, then this is where I introduced RTMS. And after RTMS is ketamine, after ketamine is ECT. So that's where I step in. For RTMS does not replace ECT because ECT remains the gold standard when it comes to the treatment of major depression. RTMS fails in treating psychotic depressions versus ECT, which could be used in that. However, with ECT, a person it's quite intrusive. The person goes into uses a general anesthetic. They're sedated. They get an electrical current that's passed through their skull to induce a limited seizure, memory impairment as a result. But usually around the treatment time. ECT is quite safe, so they go to they drive to the treatment and drive back. So ECT doesn't, TMS doesn't have the same efficacy as ECT. So it falls earlier into my stepwise approach. The reason it doesn't, it's not widely used is again the adoption rate by provinces and having it on the benefit grids of each province. Even right now in Nova Scotia, it's not on the benefit grid of the province. So our clinic still operates. So when we opened our clinic 5 years ago, there was no other TMS facilities. Now that there's TMS in the public system, this has been basically brought in by the donations and individual initiatives. So it's resource intensive. It requires a lot of commitment from patients, but I think it should be widely available because it is quite a useful treatment for managing depression and other disorders.
Perfect, thank you. There is a question too, speaking to a patient who is suicidal. So would you consider this type of treatment for someone who is suicidal?
So it depends on why a person is suicidal. First of all, to decide on where to go there. There is evidence and there's studies on for TMS and ketamine in the treatment of suicidality. Janssen is trying to get Health Canada approval for a new indication for S-ketamine, the intranasal ketamine, for urgent use in depressed patients who are suicidal. so depressed patients with major depression who are suicidal, I think ketamine is great. So is RTMS. There are also studies done out of Toronto at the University Health Network where they provide accelerated course of TMS for patients who present to the emergency department with all-cause suicide, and it has shown that it has decreased their admission rate by 50%. So I would be more liberal in offering TMS for all-cause suicidality. Of course, it's very important to address why a person is suicidal, if it's related to a character pathology or if it's related to a major depression or psychosis. So that the cause has to be assessed, because if it's related to psychosis, it's a different treatment algorithm. Ketamine, however, if someone's depressed and suicidal, yes, I would offer ketamine.
Yeah, like you said, it's circumstantial, right? Like every patient's journey with treatment, program, whatever it may be, is completely dependent. But thank you for addressing that and providing multiple examples. That's great. So would RTMS or ketamine be contraindicated for someone with a major neurocognitive disorder and also treatment-resistant depression?
Yeah, that's a great question. I would not offer ketamine for someone with dementia. However, TMS, I wouldn't say it's contraindicated. I think it's worth a try, but again, when it comes to a failing brain on account of dementia, are we dealing with behavioral and psychological symptoms of dementia at that point? So ketamine or TMS would be very safe. I would be less inclined to offer ketamine for that. It will be TMS that I would consider, plus ECT.
Perfect. Thank you so much. So you kind of spoke about this prior in terms of like addictiveness and everything too within ketamine, but at what point should ketamine treatment be discontinued if a patient is not responding?
After an acute course, if the patient is not responding, then I would discontinue it. So you would know in the first month if that person is going to require further ketamine or not.
Perfect. Thank you. And then is RTMS as effective in treating bipolar disorder as it is for unipolar depression, so major depressive disorder?
That's another great question. So the issue with bipolar disorder when it comes to ketamine and TMS, I'm just going to use both here, is that both could induce a manic episode. In the treatment of bipolar depression, they could be used with caution. They're off-label still because they're high risk of manic activation. So yes, they could be used there, especially if the depression is refractory, with the caveat that the person needs to be made aware that there is a risk of being flipped into mania.
Perfect. Thank you. So speaking to ketamine treatment, and you said usually the month is like an indicator. How many sessions are held in a month for ketamine treatment?
So usually around the 6 to 8 sessions, depending on the protocol.
Thank you. And then there's some questions too about headaches and any type of brain trauma when using RTMS, if you could speak to that a little bit.
Yeah, very informed crowd there. So the main side effects of TMS includes manic activation. People with epilepsy have a higher risk of developing seizures. People who are prone to headaches could have worsening headaches. When it comes to traumatic brain injury, it doesn't have any deleterious effect on brain injuries. However, it could worsen just if there's chronic headaches or bringing in your ear tinnitus, that could be worsened there. So I would use it with caution. But if there's a TBI and depression, TMS would be very suitable there. TMS also could increase scalp pain because with passing that electrical impulse, it stimulates the muscles, the masseter, the temporalis muscle, frontalis to just keep contracting. So it could cause headaches that way.
Perfect. Thank you. So kind of blending both ketamine treatment and RTMS, the question is, would you ever use ketamine treatment and RTMS concurrently, or would you choose one over the other?
So the evidence is divided there. I know of treatment centers that use both concurrently. I know of others who say that they work in opposite directions, so they wouldn't offer them together. The way I approach it is that I would like to offer TMS first if it's indicated for the person, because it has overall lower risk and it's more tolerable. Then I would go to ketamine. But I know that there are centers that offer both alternating.
Perfect. Thank you. And then there's questions too about like pricing compared between RTMS and ECT treatments. So if you could speak to like how expensive is it RTMS compared to ECT?
Well, that depends on where you live. So if you live in Saskatchewan, if you live in Ontario, most people can get RTMS for free. ECT is always for free in Canada because it's offered through each province offers that. But again, the issue is to get ECT, you need a psychiatrist, you need to have demonstrated that it's a treatment-resistant depression and such. So it's an access issue. For TMS, it depends on where you live. However, the concern with TMS is that in the provinces that it's not covered, a lot of the insurance companies don't cover it. Blue Cross does cover TMS for CAV veterans and such. So that's good for them. So it really varies from one place to the next.
Yeah, that's what's hard with like national scope, right? Is trying to speak to each respective province or territory, is that it does 100% fluctuate, but there's definite insight there. So I appreciate that. Thank you.
But ECT is free throughout the country.
Okay, that's good to know. So can someone ask for ketamine treatment from their health provider, or do they have to have a specific referral? Like what would kind of the process be there?
So it again depends on the SOPs of the specific clinic. I'll talk about our clinic here. As we would request that we get a referral from a physician or a nurse practitioner. We would, because our clinic is run by psychiatrists, we do our own psychiatric assessment to determine the suitability, looking at the exclusion and inclusion criteria, and then after we've done our own assessment, we would feel comfortable to prescribe this treatment. So it really varies from one place to the next.
Perfect. Thank you. So can RTMS or ketamine be the first point of treatment instead of waiting out the antidepressant trials?
Yeah, it's a good question. So I would generally ask a person to try an antidepressant first. I mean, for TMS, the concern with TMS is that any responses are not robust, that there's a fade out effect. So after an acute course, if they're not on some sort of medication to keep them well, they're gonna dip. But with ketamine being the control around it and it being higher up in the algorithm, I would see it as swatting a fly with a hammer. You just jumping to the end of the algorithm before trying the first couple of steps. I mean, someone could get ketamine on account that they failed two antidepressants, that they couldn't even tolerate them or they didn't respond. For TMS, I'd be open to considering offering TMS initially, but I would advise the patient that the effects could wear off, and then either they're going to be a lifetime of TMS, or that they should consider an antidepressant to stop them from becoming more depressed down the road. I would generally advise that the antidepressant is tried first.
Perfect. I really appreciate the analogy of the hammer and the fly. I think it really puts it into perspective. So appreciate that. Thank you. Speaking just to depression assessment, which depression assessment scales do you like to personally use?
So for ketamine, we do use the MADRS because it's quite specific, and a lot of the depression literature is based on that. For TMS, we administer the PHQ-9 and the G87, which is self-reported by the patient, and it allows ease. in that the patient could track their own response over time.
Perfect. Thank you. So is RTMS effective for a secondary depression caused by severe GAD?
Yeah. I don't think that TMS would be as effective in treating this as if it would be in treating depression. So the efficacy of RTMS in managing depression is that a third would have some sort of response, a third would have full response, and a third would have no response. I think these numbers will be a little smaller, not a little, less when it comes to generalized anxiety disorder. TMS could help with generalized anxiety. It has some evidence in it, but I don't think that TMS is as effective as an antidepressant, for instance, when it comes to generalized anxiety. I would recommend that someone be on an antidepressant plus TMS.
Perfect. Thank you. What level of evidence is there that RTMS can treat PTSD and CPTSD?
So for complex PTSD, I think it would help bring down the RPM, the level of hypervigilance, some of the core symptoms of PTSD, and also for PTSD. Will bring down some of the core symptoms. Of course, psychotherapy remains the main treatment. It is another, when it comes to patients with PTSD, there's a lot of instances where patients have intolerance to serotonergic agents. So they cannot tolerate antidepressants at higher doses or antidepressants in general. I find that RTMS would be helpful in bridging that to and the tolerability. So the number, I'm not sure if I have the number of how effective it is, but I can tell you it's a very good option in the treatment of PTSD and CPTSD, in addition to psychotherapy.
Perfect. Thank you so much. So how does ketamine affect the liver as compared to lithium?
So lithium generally affects the kidneys because it's excreted primarily through the kidneys. So over time, it degrades the kidneys. I don't think that ketamine would affect either in the long run.
Perfect. Thank you. There's lots of questions too in regards of wait times. So what would the kind of process be in terms of the waiting process for either RTMS or ketamine?
Again, because the healthcare is provided provincially, it would vary from province to province, a private facility versus a public health facility. So in our clinic, the wait time for TMS is about 2 weeks. Ketamine is about 3 to 4 weeks before they get treatment, from referral to assessment. In the public system, it's a little longer because there are other, again, more demand, and in Nova Scotia, there's no publicly accessed ketamine treatment. So it would vary from one place to the next.
Okay, thank you. And then you spoke about psychotherapy as well briefly when discussing PTSD, but where does psychotherapy fit into your approach to depression treatment?
I think when it comes to the treatment of major depression, psychotherapy is a cornerstone. Medications could help alleviate the burden of the illness, but still learning to live with a chronic condition like depression, like PTSD. Therapy is important because I view these disorders all as chronic, and reaching new levels of adaptation to live with this condition is important. So I would say that psychotherapy is as important as medications. There are some patients who has psychotherapy is clearly the only way and the main way to treat their depressions. There are other patients who I'd say medications first, treatments first, then psychotherapy to complement. But either way, I think psychotherapy has a role in all spectrums of depression.
Perfect. Thank you. And then I think we have time for one more question. So I think this is kind of an interesting one, and I have a feeling this could be a much broader conversation. Maybe it's on webinar, but are eating disorders an issue for ketamine treatment, specifically food avoidance when depression symptoms are present?
Yeah. The simple answer is I don't know. It is a very complex issue because with eating disorders, it's a very fine balance of biological and psychological, hardware and software disturbances. I don't think there's enough evidence right now to explore the role of ketamine in the treatment of specific specific eating disorders. So, and I haven't had any personal experience in treating eating disorders with ketamine. So we are totally on the off-label territory here. So I don't know.
It's an area of research that needs
Mhm.
to happen then. So that's interesting that it was provoked through this. But yeah, definitely somewhere that further research can be conducted.
Yes, and it's a very interesting question.
Yeah, for sure. And then we can end off on this one too. Can a GP prescribe ketamine, or is it recommended to be prescribed and monitored by a psychiatrist?
So a GP can administer ketamine, but in the treatment of psychiatric disorders, I think the safest and the most appropriate is that a psychiatrist assess, prescribe, and monitor, especially for where we have clear evidence in the treatment of major depression, but the other subtleties of mental disorders, as we have been discussing, what eating disorders, where are we? Those areas of less research, I think a psychiatrist should be involved, and for the use of esketamine, for instance, it has to be a psychiatrist prescribing it. But I know
Perfect.
that in Toronto and in Ontario, there's a couple of ketamine clinics run by GPs.
Mhm.
But I think the safest and is to have a psychiatrist oversee the process.
Great. Yeah, thank you so much. I think that answered like 6 or 7 different questions at one time, so that's great. Well, thank you so much. Like I said, when I reached out initially about this webinar, this is a topic that a lot of people have really wanted to explore more, wanted to gain more insight. So thank you for providing your expertise and your professional insight with all of this. And we really appreciate your time today. So thank you again.
Thank you so much for having me. It's been a pleasure.
Of course. Yeah, hopefully we'll have you again soon, maybe for another more in-depth webinar. But for everybody else attending today, thank you so much. We will be sending out a follow-up email with a copy of today's webinar recording, the slideshow that was presented, additional resources that we will follow up with about, also your CEU certificate as well. And there will be a link to register for our next webinar taking place on Thursday, December 1st, between 12 to 1 p.m. Eastern Standard Time. That will be exploring the introduction and measurement of moral injury. So until then, we'll see you. Take care.